Hi, so my name is Sydney McQueen and I'm a MD PhD student at the University of Toronto, working under the supervision of Dr. Caroline Moulton. So today I'm going to be talking to you about the work that we've done to identify different states of stress in surgery. So there's increasing recognition for the high levels of stress among healthcare professionals, and the stress is not only damaging in terms of physician wellness and contributing to burnout, but we also know that it can impair performance. And that's particularly concerning in surgery, where we know that high levels of stress can actually contribute to poorer patient outcomes in the operating room. One of the challenges with stress is that it is a complex phenomenon. And since there are all these different dimensions, we don't actually have a shared definition for what we mean by stress. And you can actually view stress from a number of different angles. Traditionally, many, including work from our own lab, have looked at stress from a physiologic perspective. So our lab used biomarkers to try and understand how surgeons respond to stress in the operating room. But there's limitations to just looking at stress from this angle. So we know that the physiologic stress that you can measure doesn't always correspond to the perceived or the subjective stress that surgeons actually report as being very problematic. We know there's other aspects of stress that are important, so cognition, or how a surgeon cognitively interprets a situation. And despite stereotypes, we actually know that surgeons feel things, and the emotionality of the experience is very important. Lastly, we know that surgeons are social beings, and working in the social-cultural context of surgery can actually greatly shape that experience. So what we learn from this is that viewing stress through any of these lenses individually can provide very important insights. To address it in practice, it may be helpful to take a step back and take a more holistic view of stress. So the goal of this study was to ask the question, how do surgeons experience stress in their practice? To answer this question, we used a constructivist grounded theory methodology. So what this approach allowed us to do is to study stress, which is a natural social phenomenon, by actually talking to the people who've experienced it. And we conducted 24 staff surgeon interviews with surgeons affiliated with the University of Toronto, and these were semi-structured interviews. And these participants were purposively sampled for different experience levels and surgical practices. And the data were the interview transcripts. They were coded by a team of researchers. The process was iterative. Disagreements were resolved by consensus. And we also took the emerging themes or ideas back to surgeon participants to see if it resonated with them. And so what we did is we explored these antecedent dimensions of stress, so the physiologic, the cognitive, the emotional, and the sociocultural, and we explored how they combined and were filtered through individuals to actually produce particular experiences. And from this analysis, we established a conceptual framework for identifying states of stress in surgery. And we define these states of stress as multidimensional compound abstractions that correspond to ways of thinking, feeling, and being. So at the broadest level, these states could be categorized as either fluent or fractured. The fluent states were described as coherent experiences of control, so where all the dimensions were intact and working together harmoniously. And surgeons described that these experiences could be kind of neutral, or they could be very positive experiences. And I think it's also important to note that these fluent experiences weren't always completely devoid of stress, but actually many participants talked about how lower levels of stress, or what they called positive stress, could actually be very beneficial. So one of those states was that of engagement, and surgeons described how that positive stress could actually help them attend to what they were doing. And because of that heightened attention, it could actually be beneficial for performance. The positive stress is something that you always should have prior to surgery. If you go into surgery as if you were drinking a cup of coffee, then something is wrong, because then you're not as focused as you need to be. You can really hurt someone if you're not at your best. And this idea of performing at your best was something that came up a lot in the discussions. And some surgeons actually thought that there might be an ideal state beyond that of engagement that really could help surgeons perform well. And that was the state of flow. And this is a state that has been previously described in the psychology and elite sport literatures. And with this state, it is this intensely positive state because surgeons are very challenged by what they're doing, but they feel that they actually can complete the task. So in this state, they have very sharp attention, they're very focused, it's enjoyable what they're doing, and actually to the point that they don't necessarily notice that time is passing. When I'm doing an operation that is a little bit out of the usual, that requires all of my expertise, I kind of have the sense that, boy, I'm lucky to be here. I'll focus on what I'm doing, all of a sudden I'll look up and it's an hour later and the task is done. And while some surgeons thought that, this is an ideal state that we should try to attain for performance, not all surgeons had that view, and some actually thought that perhaps there isn't an ideal. And what is ideal might depend on the particular surgeon or the case they're doing or even the type of day that they're having. And another thing that was identified is that working in this state of flow might actually pose a risk because since there is a lot of positive stress, there is that challenge, there might actually be a danger into tipping into a state of fracture. So these fractured states were described as incoherent experiences of disorder. And because of that, many surgeons described them as negative experiences where they lost control of the situation. And surgeons talked about how these types of states could actually be very hazardous. One of these states was that of disengagement, and surgeons described how particularly lapses in attention in this state could be detrimental. There was more than just cognition described. It wasn't just the attention, but all these other factors could influence the state. And surgeons talked about how disengagement could arise from a number of different situations. It may be that the work is truly boring. It could be disengaged for other reasons, like they're unhappy with the situation they're in, or they may have a bad OR team. They may have gotten canceled. So I think we can see from this quote that, there's emotions of being unhappy or the social environment they're working in. And we actually heard that in many of these states, all of these different dimensions of stress could be implicated simultaneously. And that was the case for another state of fracture, which was distressed. And this was described as perhaps, what you would classically think of with that acute stress reaction. A surgeon encounters an unexpected bleed in the operating room that they're not able to control. And many participants describe this state in a similar way. When you're in a difficult operation and things start to go a little south, I think it's as if it was your third day in practice. That feeling of, I just want to be dead, I want to crawl into a hole, I want to disappear from the universe right now. And what we heard from participants is that these fractured states could actually be very detrimental to them as an individual, as well as their ability to perform. And surgeons described how it can actually be difficult to navigate these types of states in a surgical culture, which has traditionally equated stress with weakness and silenced discussions of these types of fractures. I could not talk to anyone about this. I could not, it was not a good time, and very negatively impacted my health, my family health, my extended family health, like parents, brother, wife, kids. Couldn't talk, couldn't eat, nobody helps you with this. So what I think we can take away from this work is not necessarily an exhaustive list of all the states that a surgeon might experience, but by starting to think about states in terms of fracture and fluent, in providing that vocabulary and the language, it may help surgeons identify what state they're in. And if it is a state of fracture, to then maybe start to identify where does that fracture stem from. The next step from there is to identify strategies that can actually help surgeons navigate these types of states, whether that be mental skills training, deep breathing, or biofeedback to achieve ultimately states of fluency. Thank you.